So thank you very much for the kind introduction. So I don't know, Andrew, if having children, a part of the family planning, is good or bad for MS, but this is out of the topic of today. So we will talk about DMT use in pregnancy and in person with multiple sclerosis. Those are my disclosures. So just in a treatment decision in multiple sclerosis, there are several factors that we need to take in account. But I think pregnancy is really one important factor that we have to discuss when we decide which DMTs to start. So here, just a reminder of the pregnancy or the family planning in multiple sclerosis. So there have been, for many years, a woman could not have children because we said having children or having pregnancy is not good for MS. So you sometimes have people or women that are 60 years old and they tell you, well, I don't have children because my MS doctor told me not to have one. So I think this is something that we now have to say that it should not be the case anymore. And then we have the risk of undertreating women in many different diseases because we think, oh, we're going to use the DMTs or the treatment that will not harm a potential child in the future. So what do we know about multiple sclerosis? So we do know now there are strong evidence showing that actually pregnancy reduces the relapse rate, especially in the third trimester, so we should not forbid a woman to have a pregnancy. And we also know that there can be a rebound effect in the postpartum period, and that now we have to handle this. And maybe also very strong evidence that if you use assisted reproductive technology, you might also have an increased risk of a relapse, and then you have to take this in account when we discuss with women. And then we also have some evidence that having children or having multiple children might slow down the progression in MS. So I think there are no reasons to tell a woman not to have children. So what do we have to take in account in planning, in family planning in multiple sclerosis? I really like this publication from a group of experts in MS and pregnancies. And I think you have to look at the preconception before a woman is even planning of having a pregnancy. Then you have to know how to handle during pregnancy. And then you have to handle the postpartum period. So what do we have to help us in DMT use? So we can look at the compendium. So if you look at the compendium, you're going to undertreat women because you're only going to give them maybe interferons or glatiramer acetate. So here you have a risk of undertreatment. So you really need to have different consortium or different guidelines or recommendations. So there are many different guidelines coming from different places in the world. I highlight the first one because we had Professor Christine Lebrun-Freinet, who also participated to the French guideline where they did a Delphi survey. So they really had an expert panel in discussing how to use DMTs in pregnancy. Then you have the German DGN guidelines that we often use, also that really point out what recommendation we could have. Then you have the British recommendation that you can also look at. And then you can, I really enjoy this publication from several people involved in multiple sclerosis in pregnancy that gives recommendation or discuss how we can use this. And maybe you can look, often we say in science there are very few women first and last author. I think this is a paper where you have almost only women as the authors. So now we're going to discuss some cases. So this is the first case that we had in our clinic. So you can see this is a 70-year-old woman, a girl, and she was diagnosed when she was 17. So at that time, 2017, we discussed which treatment, and finally she was started on the fingolimod. But she comes back to your office just that when you started fingolimod, you see her the first time, and after 3 months she comes back and she says, "Oh, I'm pregnant." So you just started your fingolimod, and now she tells you you're pregnant, so you stop the treatment. So this is the first point that I want to make. When you have a woman, even if you don't think about it, you have to know that unplanned pregnancy or unintended pregnancy are very often. And here in Switzerland, you can see that almost 1/3, or some people say even half of the women get pregnant without having planning it. And you can see, so here it's like you have different countries, the low-income countries, middle-income countries, and high-income countries. But even in high-income countries, you might have an unplanned, unintended pregnancy. So think about the treatment you're giving, even if the woman is not telling you that she wants children or that she's having any family planning, as it was with this 70-year-old girl. So that's the first thing. So if you look at preconception, so even years before you discuss the planning, you should think about it and probably not use DMTs that are not compatible with the pregnancy. And then you could also think, if it's a long-term desire of planning pregnancy, maybe to use induction therapy so that the person will not be on the treatment in the longer run when she plans to have a pregnancy. So this is, so we now have this working group for Swiss recommendation that is soon going to be submitted. But this is one of the recommendations that we made, or that we propose, is that S1P receptor, they are kind of contraindicated in person who's planning a pregnancy, as well as teriflunomide. And one question that I'm asking myself, if we look at this first case that I presented to you, maybe we should not give them to very young women because they might be pregnant, and then you should anticipate that maybe she will have an unintended pregnancy. So then what do you, then once you go more in the pregnancy planning, that's something that you can anticipate, and that's the thing that we should really do. Now we should anticipate and discuss family planning before there's the pregnancy ongoing. Not like this young girl who comes to us and say, oh, I'm pregnant. Then you should anticipate. So discuss the DMTs, and if she's under a DMTs that is not compatible with the pregnancy, discuss how to change them. And how to change, you really have, so this is also a table from this paper that I really used as a line for my presentation. You always have to balance the risk for the treatment continuation and for the treatment discontinuation, and you have to take in account the mother and the baby. And you really have to balance both of them, and you should not harm the fetus, but you should also not have the woman have a relapse, because then it will not be for the long-term handling of the woman. So here I'm coming back to this young girl. So she was 17. She got her first pregnancy. Then it goes fine. The child is going very well. So we were lucky. And then we decided she tried to start fingolimod again after the pregnancy, but she said, "Oh, I don't want to take a treatment all the time." So we decided to go do this induction therapy with Mavenclad. And you can see she did the 2-year cycles of Mavenclad, and then she could have a second pregnancy, and she's doing fine, and both children are doing fine. So this is something that we also can think about when you're planning a pregnancy that is not right away. Then you can really discuss, and those induction therapies that you can use before the person is having a pregnancy could be a good option to discuss with young women. Then I take another case. So here it's a woman a little bit older, but you can see that she has a longer disease, like since 2003. And then she was under Rebif. You can see that she had many relapses here in red. So it was decided to switch her to fingolimod. And under fingolimod, she has no relapses. The MRI, everything is fine. And at that time, we didn't have that much experience. In 2015-14, she says, well, now I want to be pregnant. So you decided to stop fingolimod, and then you stop fingolimod, at that time it was discussed to start Rebif, but you don't have the time to start Rebif because actually, I'm sorry, I didn't. Actually here you can see in the yellow line, the EDSS goes up because she has a very, very severe relapse. She has an EDSS of 6, and she's in a wheelchair, so she cannot continue her project for pregnancy, and she does not get pregnant. So here I think this is something we have to discuss. When we stop the treatment, then we have to be very careful about rebound effect, especially for S1Ps. And if we now look at a different publication and a French cohort that was looked over years, so in a contemporary cohort. So you can see here the risk of having a relapse during pregnancy. So in black, it's the cohort that we see, that you reduce the risk of having a relapse during pregnancy, and then you have a little bit of rebound effect maybe after pregnancy. But here they really stratify. They look at women that had first-line treatment before pregnancy, so interferon or glatiramer acetate or DMF, and you can see that here the risk was not very high, probably because they are not very active or non-active MS. But in the group where they stopped, where they were on the second or third line treatment, so you can see most of the patients, they were on the natalizumab and fingolimod, and the treatment was stopped before they got pregnant. You can see that here, in this case, you have a higher risk of having relapses during the pregnancy. So this is really something you have to take in account, and most of the people that we contributed to the higher risk of having relapses during the pregnancy were on the treatment of natalizumab or fingolimod that was stopped before they got pregnant. So indeed, for the S1P inhibitors, so I think you have to stop the treatment because they are not compatible with the pregnancy, but you really have to be careful. And here, those are the international recommendations, but they also propose to change for another treatment, and mostly the monoclonal antibodies, to dampen the risk of having a relapse when you stop, a rebound relapse when you stop the treatment. And here are some of the time you have to be also careful when you stop an S1P before you can plan a pregnancy or you can start another treatment. And here, so if we take another case, so here this is a woman, she was on the Rebif, Gilenya. Actually, it's the same case as to that before. So she had this rebound relapse when we stopped the fingolimod, and then you start her on the Tysabri, but you see there are many years going by, so she could not get her pregnancy planning as she planned in 2016, but she had to wait until she was stable on the Tysabri, because actually when you have such a strong relapse, when you stop the treatment, she was very afraid of then getting pregnant. And then you start natalizumab, and then finally over the years, she gets a pregnancy under natalizumab and everything goes fine. And you can see here in the yellow line that she stays with a low EDSS scores and she has no relapses anymore. So indeed, I think that those monoclonal antibodies, the natalizumab, you can continue during pregnancy, and I think there are good safety evidence now that you can increase the dosing interval to 6 to 8 weeks during pregnancy, and then you go until the beginning of the third trimester where you stop the treatment, because then that's the time where the antibodies can go into the placenta. Yeah, and then another way of doing it, and what we should do actually, is to discuss the pregnancy before, right at the beginning. So here you have a patient, she was on the different treatment, Copaxone, many relapses, then she goes on to natalizumab, but she's GCV positive. Then she switched to Gilenya, fingolimod. That was the time when we did this switch from natalizumab to fingolimod. And at that time, she doesn't want to have children. But over the years, she says, now I'm planning of having children. And then you discuss, you send her to a gynecologist, a pharmacologist, and you discuss the risk. And then you change the treatment because you're anticipating that she's going to, she wants a children. So here we use the anti-CD20 treatment, the ocrelizumab. She has 2 years of treatment, she's very stable, and then she plans her pregnancy, and everything goes fine, and you can see the yellow line. She's completely stable, and the child is going very well. So I think the monoclonal antibodies and pregnancy are treatment that we are now very comfortable with to use for pregnancy stratification. So one way of thinking of it would be that if you want to go for a monoclonal antibody, if she's GCV negative, then you could start thinking about natalizumab with these extended doses. If she's positive, maybe dimethyl fumarate, especially if the disease is not very active, but then you stop at pregnancy test positive, or if it's positive, then you can go to ocrelizumab or other anti-CD20 treatments. And then here are the different anti-CD20 that we can discuss, and natalizumab, and how to handle them. But I think even if we are kind of off-label, those are the recommendations from several guidelines. So here I come to the conclusion before we discuss this in the panel discussion. So I hope I could convince you that pregnancy is compatible with multiple sclerosis. However, we have really to discuss the pregnancy planning during a consultation with a neurologist, and then we have to discuss this in a multidisciplinary manner, and then also involve different specialists such as gynecologists and maybe pharmacologists. And then we have to consider DMTs that are compatible with a pregnancy, because even if the woman says she doesn't want children, you never know, and I could show you that unplanned pregnancy are very high, also in high-income countries such as Switzerland. And then we have to adapt the DMTs and symptomatic treatments that I didn't have time to discuss now, and then avoid using DMTs with teratogenic risk. And then now we are working on the Swiss recommendation for MS treatment in family planning, and this is very soon going to be submitted. Now we are reaching the end. And I would like to acknowledge all the people with whom we worked on those recommendations. So Marie Théodin in Lausanne, Alice Monchot, and Alice Legardeur, and also the team in Bern, Andrew Chan, Michael Graber, and Daniel Surbeck, and the working group of immunotherapies. And now I think we will continue for answering all the questions in the panel discussion. So, yeah.